Good morning and welcome to Southcentral Foundation's Fireside Chat. Thank you so much for joining us. I'm your moderator, Gil Prickett, and I work here at Southcentral Foundation as the Senior Clinical Advisor for Learning and Development. In response to the COVID-19 pandemic, healthcare is rapidly changing, including here at SCF. In these chats, subject matter experts from SCF will share some lessons learned and then open it up to you for questions and comments. At the bottom of your screen, you'll see a Q&A button. Here, you'll be able to submit questions or anything else you may want to share, and I'll make sure to direct your questions to the presenters. After today's chat, we'll send you a quick survey. So please give us your feedback so we can improve the next chat. If you're having any technical difficulty today, please email us at scfnukaevent@scf.cc, and we'll have someone reach out to you to help as we're able. Again, that email is scfnukaevent, all one word, @scf.cc. Now, I'd like to introduce the panel for today's fireside chat. Dr. Michael Cooper is a board-certified family medicine provider who has been with SCF as a primary care provider since 2016. He received his MD from Michigan State University College of Human Medicine, followed by family medicine training in Duluth, Minnesota. Upon completion of family medicine residency in 2006, he completed a 2-year Epidemic Intelligence Service fellowship with the Centers for Disease Control and Prevention in 2008. Dr. Daniel Hartman serves as SCF's medical director. He supports providers in offering the relationship-based care that has made SCF one of the world's leading examples of healthcare redesign. Dr. Hartman is a board-certified family physician who attended medical school at Temple University in Philadelphia. He completed his specialty training at the University of California, San Francisco, and has been a family medicine doctor since 1999. Michelle Aregood serves as SCF's Director of Quality Assurance. She has been at SCF for more than 13 years. Her team oversees the execution of activities that ensure SCF's quality management program complies with local, state, and federal regulations related to accreditation, risk management, safety and security, employee health, infection control, and legal requests. And now, I turn over to our panel.
Good morning. Thank you, Gil. We're excited to be here with you this morning for this fireside chat to share some of what we've done in response to the COVID-19 pandemic. SCF, I'm just going to tell you a little bit about SCF at a high level. I think most of you already know us, so I'm just going to share a little bit about us as a whole. We are a vertically integrated tribal health care system. We're Alaska Native owned and operated. We serve 65,000 Alaska Native American Indian customer owners across our region. We co-own and operate, we jointly manage the Alaska Native Medical Center with our partners, the Alaska Native Tribal Health Consortium. We also employ over 2,500 employees at SCF. So you can imagine during this crisis response to the COVID-19 pandemic, we had a lot of moving pieces to think about with 2,500 employees and serving the volume of customer owners that we serve. As co-managers of the Alaska Native Medical Center, we have a 175-bed hospital with lots of different specialties such as ICU, CCU, a NICU, a PICU, a cath lab, infusion center, etc. SCF also has lots of different services that we offer as far as outpatient, primary care, dental services, optometry. We have residential services, a detox center, cleft lip and palate, and we have services across many different areas geographically. Some of the areas that we serve, you can only reach by plane, small plane, or boat. So that's a little bit about our infrastructure. During the COVID-19 pandemic response, SCF identified 5 key areas that we were going to look at to to handle our response. And those areas include leadership, clinical operations and care delivery, business operations, our overall infrastructure, and our workforce. And in those key areas, our leadership approach was to make sure that we were present, visible, modeling what we wanted to have happen with our workforce as far as self-care and compassion during this pandemic and this evolving situation. Our clinical operations and care delivery, our strategy has always been to listen to the voice of the customer owner, and that didn't change during this pandemic. We're a relationship-based organization, and that didn't change during this pandemic. We used our existing structures to make sure that we were moving forward in the pandemic, listening to the voice of the customer owner and listening to the people that we serve and our employees to make sure that we're on the right path to address the pandemic. Our business operations, we were able, because we have good structures in place already, such as a strong leadership structure, we have committees in place that are comprised of people throughout the organization, not just leadership, but people who are working in clinics at the ground level. We use that structure to quickly make shifts in the organization to address the pandemic. And so we were able to quickly shift to remote work, let people work remotely when they needed to, and have only the people on site who needed to be on site to serve customer owners. We looked closely at our infrastructure to ensure that we had needed supplies. We started looking at our supply inventory for PPE, of course, and looking at our burn rates and our vendors. We started looking at ways that we could support our workforce as far as daycare resources or housing resources when they needed to potentially house outside of their homes. We looked at our clothing even. Could we offer scrubs to people who needed to have scrubs while they're at work and don't maybe typically wear scrubs? So that was part of our infrastructure work. And then our workforce. We adjusted schedules. We communicated continuously. We're still doing so. We have ongoing daily updates and manager updates that we provide to our workforce so that we are transparent and providing information on an up-to-date, ongoing basis so that everybody is aware of what's happening and the steps SCF is taking to address the pandemic. With that, I think I'm going to hand it over to Michael to talk a little bit more in depth about some of the rapid change responses in the clinics specifically and what medically is happening.
Great. Thanks, Michelle. And thanks for the opportunity. So hopefully I can give a little bit of a perspective of just the provider on the ground and what we did in response to this. And so I think it was late February, early March when we started, lots of preparations already underway. Michelle was involved as well as Dan and others, but we started to realize it's really coming and we need to make some on-the-ground changes pretty quickly. And so around that time, mid-March, the decision was made to create sort of a pop-up respiratory clinic. And I was asked to be integral in the medical lead in helping create that. There were discussions about using a train-the-trainer model, something within the clinics where people can safely see customers with COVID symptoms. But we can talk about that more in questions and answers if people do have questions about that. Door screening program was set up as well in all the buildings. Employee health protocols were developed not just to screen folks, but to also determine what to do if people were exposed to COVID or positive with COVID. And again, more details are available if you'd like in questions and answers or offline. But as we were kind of evolving into this, and as I was volunteered to be the medical lead for this, I have the opportunity now to kind of look back 3 months ago and sort of reflect a little bit on this emergency preparation process. And I think one thing that I can share is I'm relatively new to SCF and to the Nuka model, and it almost seems like yesterday when I was going through new hire orientation and being confronted with this whole philosophy of Nuka and the SCF model. And at first I'm thinking, whoa, what did I get myself into? And it's all positive though. It's been this 3-year process of, learning how to practice as a provider in this system and learning everything new there, but also learning this system and learning to appreciate everything that goes into it, everything that goes into having open and trusted leadership with transparency, the emphasis that they put on workforce development. I've been through motivational interview training, team dynamic training, individual dynamic training, all of these things that have contributed to not just making, I think, me a better person, a better provider, but to creating this great feeling of teamwork and almost family that's been growing for the last 3 years has been great. But what the pandemic and the creation of this respiratory clinic has done has, for me, it's really shown me the value of all of these principles and seeing them in action when suddenly we had to take people out of their routines and out of their comfort zones and create new teams quickly and developing that and addressing issues that come up with that. But all of these principles have been just integral, I think, in making it happen well. And so just for a couple of details on the actual creation of the respiratory clinic, on the next slide, on the surface, it's not that complicated. I mean, you need space, you need staff, you need stuff, and then kind of the more complicated, the systems behind it. And so in creating, the space, that was kind of an easy part because we were reducing regular activities. There were plenty of empty buildings and clinics. And so we chose a clinic that happened to be my home clinic that had on the first floor, easy access to parking lots, access to radiology. We had, plenty of space in that clinic initially, and then we expanded just down the hallway to 1 East as we thought we might need some more space. And we had, plans to expand even further if needed, but space was never an issue for us. Staff, the surprising part to me, at least initially, was that I was anticipating getting together with the manager that was assigned to help create this, Heather Scaife, and anticipating having difficulty identifying enough people that would be willing to go into a place and say, hey, let's come volunteer in this clinic. There's this novel SARS coronavirus circulating. We don't know how it's going to hit and how big it's going to be, but we're going to be the clinic seeing these people come volunteer. And I really didn't anticipate getting enough folks, but we did, which was really impressive. And I think also speaks to the institution in this sense of shared responsibilities, shared goals, and teamwork. So we got enough, we created ready rosters, people that weren't necessarily upfront volunteering, but we might need if we did overwhelm our capacity. A big part of the rationale behind creating a dedicated clinic was to be ready for a potential surge and overwhelming the healthcare capacity of the native campus. And so we never hit that, but we were developing plans and training people up for that possibility. And there was plenty of, anxiety and frustrations that came up, at different times, even on the part of the people that were, volunteering to be there. But we addressed those, again, going back to this openness, this focus on workforce development, great communication. I think they were all addressed very easily. Like Michelle had mentioned, one of the big things that helped relieve a lot of anxiety for folks was having scrubs that they could come into work, put these clothes on. There was a shower there if they wanted. So at least you take that part of the anxiety of going home, in your clean clothes that haven't been exposed away. And that helped quite a bit. The stuff part, we were fortunate, again, in Anchorage, in Alaska, not to have a big surge and never to run into shortages of PPE, for example. But we know about the global shortages, the national shortages. We are anticipating surges. So we were putting practices in place already to start to preserve PPE. So one of the things we did right from the get-go was to say, anybody that comes in with a COVID symptom, we want to minimize the number of people that are exposed to them, the number of no CMA is going to interact with them unless they have to, just the provider is going to, which also conserves PPE because the only person that needs to get full PPE on when it's indicated was the provider. So the CMA would take that person, get them in a room right away, and then remotely, either via phone or from the door, the provider would get the history, determine the need for PPE and any testing, and then that provider would go in, usually in full PPE, get the vital signs, which we're not used to doing, but we could relearn pretty well, do the exam, and also get any kind of specimens needed, including blood draws and EKGs, things which we may not have done for many years. And that worked out really well, and it helped us get into a process where if we came to the point where we had to really be strict about using PPE and minimizing contact with folks, like in a surge setting, we were ready for that. And we also benefited, and we might talk about this more later, from just a great access to local testing. We had a walk-up testing site on campus early on with plenty of testing kits and plenty of access to people that didn't need an in-person visit. They could go over there and get testing. We set up a pop-up support clinic, so people that didn't want to come into clinic and didn't need to, but needed an injection for naltrexone, immunizations, blood draws could go there. And then the final part was, the more complicated part. The other parts required a lot of work, but the systems part definitely is a more complicated thing. But again, we were building something relatively new, asking people to get out of their usual routines in some respects and comfort zones and pairing them together into new teams. And we're having to do it very quickly. But we were building it on this great foundation that's been in the works for decades here that I've experienced and learned a lot about in the last 3 years. And I think that helped just tremendously with what we were doing. And I'll hand it over to Dan here, maybe to expand a little bit more on that.
Thanks, Mike. Well, as Mike really ably rounded up, that this was a pretty gargantuan change, and it was compressed into hours. It seemed like sometimes that we were doing things in 12 hours that we would previously do in 12 weeks. I think the foundation that we had to do this, I think, was Nuka, obviously, and Baldridge, and it served us super well. It really was the only thing we had functionally, so it's not that we had a choice, but it worked beautifully. The traditions of open communication with leadership, the traditions of trust, they really served us well from an employee perspective, and also from our relationships with customer owners. We always have really we've not really put a lot of stock in policies and procedures traditionally, and we really put stock in shared principles. And we were able to fall back on those shared principles in a flexible way, in a way that relied on the PDSA model, that allowed us to fail. There was no stigma with failure. We moved forward bravely with that, relying on just organizational principles. And that, I think, was a huge win for us. Throughout the whole process, it was interesting for me actually to see at every level, staff, customer perspective, family perspective, that the continuity of relationship and trust between customer owners, families, and teams was maintained, and we all fell back on it in a way that I think that families fell back on each other or relied on each other, and communities relied on each other. It was beautiful to watch, and it's just a point that we felt accountable to each other. We felt trusting of each other, and that was foundational to success that we had with not a lot of errors. I think not a lot of problems in the design process. A big point for us was workforce development. It's a Baldridge pillar for us. Obviously, we paid very intentional effort on things like maintaining daycare, like being transparent in our alternate pay structures, communicating what the PPE burn rate is, communicating what our testing strategies are, communicating what our service strategies were going to be on a daily basis, but also face-to-face. And our rounding structure, our planning cascade structure, our communication structures really, really, really paid off. Thanks. So some of our similarities between what we've done traditionally at SCF and what successes we've had in this whole effort, mainly continuity in relationship. We know each other. We know each other in the clinic. We know each other in administration. We know customer owners and their families. We know people's daughters. We know people's moms. And all of that relationship was something that we were able to fall back on in a really difficult time when the world was sort of turned inside out. And literally, staff were working from home over cell phones and laptops for a couple months at a time. So we were able to rely on that, as we always have. Our testing capability was remarkable in how quickly and early. We were able to develop lab testing capability. SCF and ANMC have always had a very avid and well-run lab system, and we were lucky in the sense that our lab service was very quick to obtain reagent and analyzers quickly. We were among the first customers to get Cepheid reagent. We were among the first customers to get the Abbott M2000 reagent. We were among the first customers to get Panther reagent and run those on PCRs in high throughput. We're right now, I think, able to produce 4,000 to 5,000 PCR results a day on our campus, and we're a resource for the whole state. We're a resource for the region, and that was something we could rely on as we built up systems for alternate test sites, in-clinic test sites, fast track and ER testing, rapid turnaround testing for our residential settings. When we look at relationship, when we look at our technical capacity, I think all of that just sort of spooled into our ability to transition to virtual visits from in-person visits, which was a pretty extraordinary transition. We have a graph here we'll show you in a little bit that shows how we essentially flip-flop from in-person visits to virtual visits within a matter of weeks. Village continuity care, we relied on our own systems that we had already established, and we transitioned a lot of that to virtual meetings. Microsoft Teams was a real win for us, and we relied also on our usual and customary email and telephonic communications with the villages. It's important to note that a lot of Alaska villages are accessible only by air or by boat or by snow machine, but essentially by air. So the villages actually shut down a lot of air service, and they did not have scheduled air service during this pandemic. So a lot of our planning, it wasn't just assuring PPE supply, it was actually personnel supply. And we had 14-day quarantines, not only if you came into Alaska from out of state, but if you landed in a village council might have decided that there was a 14-day quarantine. So how did we manage the testing and the staffing of our clinics, and in conjunction with tribal councils, in conjunction with village air services? We have a last point on this this one slide here is that we have a tradition of working hard to do today's work today. And it's something that is sort of in our DNA. We work in the clinic, in administration, in planning, in quality, in behavioral health, wherever we are, we try to do today's work today. We try to sort of pull the work in and do it as quickly as we can. And that actually really, really helped our planning cycle. It helped tremendously because we were able to just get the work done, essentially, and not table stuff. Some of the wins that we can look at right now are essentially based on our Nuka system. If you think about what I just spoke about, it's all essentially, there are systems that we already have established, and we just sort of spooled them into telehealth, or we spooled them into virtual type care. And we relied throughout this entire process on the strength of our integrated care teams. And everybody stood up, everybody worked hard to transition to telehealth, which was essentially our main work in this transition, along with reestablishing flows and services, was to take all of our clinic staff and maybe send half of them home or 2/3 of them home to their homes and work over cell phones and laptops to do encounters either telephonically or by video. To build all of that, we fell back on our 4 ovals, we fell back on rounding, we fell back on our planning cascade, and all of the Baldrige criteria that we have, it's like rebar and electrical work in our system. We don't even have to think about it, it just happens. So that was a win. Later, maybe Michelle can speak a little bit about employee health and our if-then protocols. I think that our staff felt very comforted that we were paying quite a lot of attention to safety. We from a strategic standpoint, looked at leadership as our senior leaders ran this response. We didn't establish an incident command. We understood from the get-go that this was going to be a long-term effort and that we needed to design for whole system performance. So we never actually stood up and ran a core incident command that we would then stand down. We worked with our leadership, our senior leadership essentially ran this with an eye towards strategic outcomes. Another last point in terms of success for us or a win would be just the tradition of transparency and trust. We were able to communicate on the daily to folks within our employment, but also in our community where we were, what was happening with testing, what was happening with our negative versus positive rate, what was happening with our staffing, what was happening with our alternate pay structures, and we were able to answer questions because of our Baldrige structure. We were able to answer questions empathically and with honesty. I'll toss here to Michelle.
Thanks, Dan. I want to go back a little bit to what Dan said about just kind of organically how we did some of this. I really liked how you described that. I would agree with that. I think in the beginning it was hard. It was a lot of unknown. I remember a lot of long days, maybe 15, 20-hour days. Many of you were probably experiencing those days as well. In the beginning, Dan alluded to not standing up our traditional incident command, and that is true. We have an emergency management plan, and in that plan, we would typically stand up a traditional emergency management incident command, and we recognized in the beginning that the duration of this pandemic or this emergency would not allow us to stand up a traditional incident command. So quickly, our vice president leadership team and our president CEO became incident command, still are incident command, and are utilizing an addendum we added to our emergency management response plan, which is called our pandemic addendum, which we'll use moving forward even after this pandemic with COVID. And so that was really nice to be able to do that and stand that up. I think that our employee health and testing response was and remains really robust. I think Dan and Michael and I, we work closely together to make sure that we're answering questions that employees have and making sure they feel supported. Our if-then table that Dan alluded to was established to answer questions for employees throughout the organization for things such as, if my aunt travels into Alaska and is staying with me, what happens then? Or if I am traveling intrastate, what do I do then? Do I get to come to work? Do I not get to come to work? So it's about 15 pages long now, this if-then table. There's lots of different questions. And what we're finding is that, people are nervous. This is a nervous time, and we don't necessarily have all of the answers all the time. And so it's really nice. We appreciate when employees bring up questions that they want answers to. And together, Dan and Michael and I get together and we talk through those questions, and we say, we look at local and local guidance from our Department of Health and Social Services and the Centers for Disease Control and Prevention and the WHO, and we come up with the answers that employees are looking for, and then we publish this out to them. And I think those are really big, important things to help employees feel supported. We've heard a lot of good stuff about that. I think the transparency that we've been able to provide for employees, we committed early on to letting employees know the daily case count in Alaska and globally, so we do that. And we also let them know if there are cases on our campus. We don't let them know who. We protect people's privacy, but we do want to be transparent. This is an example, the slide that you're seeing now, of just the first part of our daily update. We started providing daily updates via email to the entire workforce in late February, early March. This is still going on. We provide lots of data on what's going on our campus, but also what's going on globally. And then also in the daily updates, we provide information as to testing. Where can an employee get tested? How can their family members get tested? Any changes we make to policies or procedures or temporary procedures we may have implemented at SCF to address this pandemic, or things like lodging or scrubs we add to this so that employees are well informed at all times. Much of what goes into this daily update are questions that come to us from employees that we recognize maybe the entire workforce wants to know the answers to these questions, so we publish that out.
Thanks, Michelle. So I wanted to point a graph out here, which I think is super interesting. It's a graph of our in-person visits versus virtual visits. On the left, the upper line is the average day-to-day, week-to-week in-person visit, which was trending, I think, in the range of about 540 visits per day. And then as you move to the right, you can see it tanked in a matter of a week to quite a low level. And I think pretty much everyone listening in here had a similar experience in how communities just decided to avoid the medical campuses if they could. The lighter line that is crawling up and crossing over is the number of virtual visits. And I think we pushed 400 visits a day in combined virtual and in person. As you move to the right, you'll see that we're starting to crawl back with in-person visits with our reopening. And our virtual visits are crawling down, and that's a function of the fact that the integrated care teams are obviously the people that are delivering this care, and if they're in-person visits, they're not available to do as many virtual visits, but we're now hybridizing that whole thing, where our daily schedules in clinic are salted with video visits as well. So we're meeting our customer owners where they are in terms of what their needs are. A number of things that we've kept open include the support clinic access on the first floor of our primary care building, alternate care pathways for dental, for behavioral health, optometry. We're really obviously not open completely yet, but we're moving towards the new normal, which we hope is a healthy one for everybody. Mike, do you want to?
Yeah. So this slide talks about some of the lessons learned, and some of these points up there are more specific to my perspective from on the ground in the respiratory clinic. And I reached out to Heather Scaife, the manager, and Ellie, the CMA supervisor, for their thoughts too. And one of the first things that they mentioned was just the immense amount of work. And all of you are familiar with this pandemic. And Michelle had mentioned long days. And Heather and I had mentioned we don't remember most of the beginning of April. It's just all one big blur, and especially for her, I think she did most of the work down there. And so the importance of good communication and meetings, not obstructive meetings, but frequent meetings, ensuring everybody is okay with flexibility and change, and meeting them where they're at. The second point there is constant communication and check-ins. We have a tradition of check-ins here. Hey, you have a question, you have a thought, you have a concern, you ask someone, hey, can we check in real quick? And you go sit down and you talk about it. And like Dan had mentioned, you address everything right away. Don't leave it for later. And so that's key, I think, especially when you're in this new pandemic, everything new, low level of fear and anxiety for everybody on some level, just with all of the uncertainties. And especially in this setting, you almost have to just plan for the need for frequent check-ins and concerns and anxiety, and just embrace it, schedule it in. Don't let it annoy you, because if you're not ready for that, it will. And anticipating difficulties with changes, a lot of providers, a lot of people at every level benefit, and they operate with definitive guidance. They have their roles and routines, and they follow protocols, and they don't like it when things are changed sometimes, or it's hard to adapt. And this was a classic example of having to be flexible and have almost constant changes. I don't know how many times I'd sit with Dan and others and come up with an algorithm or a flow chart, and then the next day you're changing it because now diarrhea is a symptom of COVID-19 or something else has changed. And just constant changes, being flexible with that, and again, looping back to the need for good communication at all levels. Having empathy, I think we all do, for anxiety surrounding the unknown was important. Embracing that unknown and embracing the fears and the transparency that Michelle mentioned, being transparent about information and also your uncertainties. And if you make mistakes, being upfront about those. And at the same time, trying to exude some level of competence, even if you're not always feeling completely confident about what's going on, not necessarily showing your lack of confidence in what's going on, but sharing, being transparent about where you're at, why changes were made, why things are changing today compared to yesterday helped a lot. We had minor challenges just integrating people sometimes that were not comfortable being there, but were there because they were on the ready roster or were being told that they may have to work in that clinic setting sometimes. Just minor things that, again, were addressed really easily, I'd say. And the last comment that was made from Heather was, there's no such thing as one little change. One little change that goes unaddressed or doesn't make it to every single person has the opportunity, and especially in a case like this, to just snowball and create much bigger changes somewhere down the line. And so it's just critical, especially with so many changes, to focus on communication, openness, and to disseminate all that information broadly and making sure that it's actually being heard and implemented on those levels. And that's just a difficult thing in any setting, and especially in a setting when the consequences of things falling apart are greater, like they were here. And I don't know if Dan or Michelle have any other thoughts about lessons learned they want to share.
I think for me, some of the lessons that were learned were really in the beginning, thinking about the quickly identifying the organizations that we were going to go to for our information, and meaning, is it going to be the CDC? Is it going to be the WHO? What is going to be our primary source of information that we're going to be using? So that was something that we needed to quickly identify. I think also through this, everyone was trying to address what they saw in the media or what they were hearing in the news or from their family members. And so in the beginning, lots of different processes were being established individually. And I think a lesson that we learned is to quickly start putting information out to the workforce to let them know that you're paying attention to this, that leadership is paying attention to what's going on, so that we can have an organized, systemic approach to what we're doing. Otherwise, naturally, people will start to address issues that they see coming up and hearing. I think that is something that we learned through this, is that quickly we need to let people know that we're paying attention and that we're going to have an organizational approach to how we're addressing this. And as you all know, this pandemic was and still is evolving very quickly. And so, like Michael said, we have to evolve and move and shift quickly with the changes. And part of what we've been doing is everything that we publish, we always are saying this is subject to change. Even our if-then table, it changes all the time based on new guidance we're getting. So those are some lessons, just letting people know this isn't a static thing, that it's changing all the time.
The only lesson learned that I'll speak of, I mean, there are many, but was the simple fact that we could do this. I don't think in my wildest dreams I would have thought that this would have been something we could do, honestly. Restructuring entire services, outpatient, behavioral health, urgent care, inpatient, specialty interactions. It's extraordinary what we've accomplished, I think. Every campus in the nation has done it as well, and it's just, I think it's a compliment to human nature and adaptability. So maybe some time for questions. I think we're under 20 minutes to go. Maybe Gil, if questions could be opened up.
Absolutely, and we've had several folks ask questions throughout the presentation this morning. First thing I'll share, though, is a comment from someone. They said, please thank the speakers for being brave and staying the course. It's been an intense period of time, and I admire their willingness to be in it together, 6 feet apart, of course. So just want to acknowledge you for that. In no particular order, here are some of the questions that we've received this morning, and I invite our panelists to respond. If we had to do a respiratory clinic again or something similar, what would we change, if anything? So maybe
this is Dan. I'll chime in. I don't think we would change anything. In fact, we are ready to do a respiratory clinic again. We're watching on the daily our numbers, and we have very structured and intentional plans to pop it back up if needed. So essentially the same structure. We did find, we ran into problems with the training of trainer approach. Initially, we had an established plan for infectious disease response that came up out of the Ebola response and then the Zika response. And so we had sort of structured systems for rapid response and like code-like response for experts to help clinics and teams in individual case decision-making. That actually failed early on in COVID because the response was just so systemic. You know, it was just there were so many teams that needed help that that's why we pivoted to the respiratory clinic for a lot of different reasons. And so a quick answer is we would do it again just like we did it.
And I agree with that. But I would also say that we were never at least tested in a meaningful way. Like we never had a huge surge and we never overwhelmed our capacity here. So I agree. I can't think of anything systemic that could have been or should be done differently. And if the surge were to occur, maybe other things would come up that we would be more aware of and say, oh gosh, we should have done this, should have done that. But we were planning all along for that potential surge in, all different ways. And I agree. Thanks.
Yeah, that's a good point. We need to be conscious of our privilege that we did not catch it in the shorts the way other communities did. And we're very conscious of our privilege there. We did not talk about our fast track emergency department and inpatient flows. We didn't talk about our alternate hospital site. We actually have a university arena that was structured as an alternate hospital site. In any event, good point.
Thank you. Another question, and this is about something that we talk about a lot here at Southcentral Foundation, but which other folks may want to know more about. And was wondering if someone could please give an example of PDSA, Plan, Do, Study, Act. They're all looking at you, Michelle.
Yeah, they're all looking at me. An example of how we might use that here. I can tell you that just overall, everybody at SCF is empowered to use the Plan, Do, Study, Act model anytime that they notice there's an improvement that could be made throughout SCF. There's lots of different things that are happening right now with regard to how we responded to COVID. For example, we are gathering information about what services or what things we're going to keep doing post-COVID and that we're going to keep trying. Right now, a big pilot for us, this whole thing has been sort of a pilot for us working remotely. My entire department in quality has been working remotely. I consider this a giant PDSA. Did it work? Did it not? And what are we going to learn from it? So we just submitted all of the lessons learned to leadership about this whole, what we consider a PDSA. We didn't plan for it, but we did it. And we are now studying what's working, and now we're going to take action afterwards on what's working and what we're going to keep doing after COVID as a result of what we're looking at based on what worked and what didn't.
Great, thank you. Another question that came up was, would you say that transparency in the light of change was one of the catalysts for SCF's successful response to COVID-19?
I think that transparency was definitely a key factor, for sure. And it was definitely one of our key success points. I think that the organization, we've had lots of feedback. Actually, to be honest, we just completed, in the middle of this pandemic, we completed our employee engagement survey. And I think the results have turned out fairly well, even though that I think that actually because of how we responded to the COVID pandemic and because of our transparency during this pandemic. Dan or Michael, would you like to add anything to that?
Oh, yeah. Transparency is DNA for us, and it's just that we walk it, and it served us incredibly well. It was key. It was foundational. Without it, I think a lot of what we attempted would have failed or sputtered. We might have been able to prop it back up, but we didn't have a lot of sputtering, and I think that was because of honesty.
And I would just say it's hard to pick out one concept because that's critical, like you said, but everything else that, I mentioned and you mentioned, Michelle, earlier about this whole system of not just transparency, but trust and openness and building up, the workforce, every single person to work well with other people was just critical, from my perspective, as everything was new and you were shifting things around and putting them into that position. And then this sense of not just team, but almost evolving like family with a shared goal of here's your customer surrounded by this integrated care team. And that just goes so far. So yeah, transparency was an integral part, but it's hard to dissect that out and pick that as the most important part from everything else that I've seen that has helped, I think, make this response a success.
Just to add on to what Michael said, I think that one thing I noticed is that so many voices came together and became one voice. I found it really interesting that, while quality works closely with operations to support operations, Dan and Michael and I don't work together every single day, but during this pandemic, we've been working together quite a bit, and it's been so easy. It's just been a really nice thing that we're doing together. It's just been really, really easy. And so I think that so many voices have come together and just become one because we're working towards this common goal. It's been nice.
And I did have a last thought last night too about family. It's, in families, you do not have an absence of disagreement and different opinions and fighting, but you have that, shared sense of goal and responsibility. And we certainly had plenty of not just, arguments or disagreements, but just, I think this is the right way to go. I think this is the right way to go. Let's talk it out. Let's come to a conclusion and then move on. So I think that was my thought last night was, yeah, families disagree all the time, but you're moving towards the same goal. And that's kind of the sense that I had here.
Thank you all. Another question that we have is, how would SCF operate if leaders in the organization became ill with COVID-19?
Well, I'll take my perspective, and then you guys can. That's a personal question, I guess. It would operate fine. It would operate exceptionally well, and I would say seamlessly, almost. We have a very flat organizational structure with a lot of responsibility that's shared. We work hard to co-create, and that leads to ownership. That's actually our acronym for leadership. So all of our leaders at every level are supported in standing in the gap, doing what they have to do to make it work, and taking responsibility for making it work. And so our planning processes for this response were really an accelerated version of our normal planning responses. We really just put the accelerator down and moved everything a lot more quickly, but at the same time, we were still co-creating, and we still had buy-in because of that, and also resiliency because of that. So if anyone were to become ill and be gone for a while, there would be plenty of people to step up.
And I'll just add to that. I think that's perfect. I think that also our senior leadership has planned for this. There is our president and CEO put in place an executive leadership experience program, and so we have executive leaders, we have senior directors, we have our 4 oval structure. I agree with everything that Dan said, that we have planned for this, and there are lots of people in place to make sure that everything runs smoothly. It's our president CEO's goal to make sure that that things are running smoothly so that we can maintain services for the customer owners that we serve.
Thank you. Another question that we just had was, are our employees also customer owners? And I started responding online and saying many, but not all. And I wonder if anybody else would like to weigh in.
I concur with you, Gil. Many, but not all. I think that upwards of 60% of our workforce are customer owners.
And that absolutely helped us. That was, it helps us every day. It's helped us for 20 years. It's not a liability. It's one of the greatest assets that we have, because as staff use their voice, they're using their voice as a staff member, but they're also using their voice as a customer owner. And we hope that in the co-creation of services, that staff are looking towards what they would want their auntie to get for care. That's our overarching goal.
What are some of the long-term plans that SCF has to handle COVID-19? Because I think we can all agree this is probably not something that's going away anytime soon. So what are some of the long-term plans that are being shaped to address this health crisis?
Well, we view this as a 2 to 3 year project. We are creating a new normal, and we've communicated that intentionally from the start to our community, customer owners and staff, and there's been buy-in for that new normal. It's not a hard sell. It's not a difficult task to convince people of that. I think it's in every sphere of our life and economy and society that's happening. But yeah, we have a very long-term plan that relies on our staffing structure, our finances, our planning cascades. Everything essentially has adapted to this very large systemic societal response. I'll pick a couple of points. One is we've really strengthened our relationships with the State Department of Health, with the governor's office, with area campuses, our partner campuses in the city. We're very early in incident response together. So those are some areas that we really hope to grow, I think. Maybe you guys could add some more.
Yeah, and just in terms of clinical care delivery going forward also, I don't think that it was as much a big change for SCF as an opportunity to accelerate a lot of the things that were already in place that now can be accelerated even more quickly. So the ideas of not just doing virtual visits, which we've been doing anyway before the pandemic to an extent, but not moving, I think I heard Doug say it the other day, not moving just from having an in-person visit and having the same kind of visit to a virtual visit, but emphasizing this movement towards this complete integrated care team virtual visit that exists and now has an opportunity to exist even more going forward, which addresses that need to prevent unnecessary exposure to a healthcare system for people. So if they can get all of their behavioral health services and their nurse case management and their primary provider visits and all of their services that are offered to them virtually and only come in when they actually need to, that's always been in place, and that's been the push for the last decades. But now there's an opportunity to push that even more forcefully, and if the reimbursement side matches that, that'll only help that, and also help in the face of an ongoing pandemic for the next year or two.
I'll piggyback on that idea. SCF has, the idea that the office visit is a dinosaur. The SCF has long held the position that virtual care is a cornerstone of delivering excellent in-person care, and and outcomes. So in outcomes-based systems, we think that a really strong attention to virtual care is crucial, and we've always walked that walk. We view strategically this as an opportunity for us to begin a national conversation about the transition to virtual care. And I think just this last week, I believe Doug Eby and Don Berwick came out with a JAMA article that was titled "The Office Visit is a Dinosaur." So if anyone's interested in referencing that.
Thank you. We have time for one more question. The question is, how does our family medicine and kind of family medical home and population-based health orientation contribute to our pandemic response success?
Yeah, we've talked about it a little bit this hour, just this idea of this integrated care team where you don't have a provider at the center diagnosing and treating a person. You've got this customer at the center and their wellness at the heart of everything that this integrated care team does around them. And so we've already been, my experience here over the last 3 years, emphasizing how they don't need a provider visit for everything. They might need an integration with their behavioral health team, with the pharmacist, with their other social services, with the nurse case manager managing things over here, or possibly a provider visit for certain things. But we've already been focused on that integrated care team as the heart of family medicine delivery. And like we just said, this is offering an opportunity potentially to keep it even more virtual, to reduce the need, not to prevent access, but just to reduce the need for in-person visits, which might pose a risk during an ongoing pandemic. But yeah, we've been working on these concepts, and that's been a great experience for me over the past 3 years, was feeling like, it's not this doctor-centered relationship and you're going in and you're diagnosing and treating someone. I'm part of this integrated team, and I'm following the customer's lead, and I'm relying on my cohorts, my colleagues and other disciplines to work towards their needs and following their lead on that. So I don't know if you have anything else to.
I couldn't have said it better. And our response is based on that, essentially.
Well, thank you all for your thoughtful and timely responses today. In closing, I'd really like to thank our panelists for leading today's fireside chat. I'd also really like to thank our participants for joining and asking such great questions. We had a lot of fantastic questions. We'll be doing this again later today. So at 3 p.m. Alaska Standard Time, you can join us again for another fireside chat discussing this issue. So if there's more that you want to hear or more that you're interested in, please join us or invite your colleagues to join us at that time. You can find out about that at scfnuka.com. And please let us know. We're going to be sending you a survey here shortly. Please let us know if there's any lingering questions that you have, and please give us your feedback in the survey that we'll be sending you after today's fireside chat. Again, thank you so much for joining us. Take care.